There we go. A copy of this recording will be available. We have just, thank you to Troy Rudy, if he's here on the call, has put together all of our recordings. We're going to have those available for you, and I'll send out a link to all of our past recordings in the next email that I send you all with the registration for next month's link. So those will be available in addition to the one for today. Again, without any further ado, let me welcome Lisa Bromfield and Dr. Chilakamarri from Frederick Health Hospital. Lisa Bromfield has a background in education and nursing and is a former special education teacher. Experience in the emergency room and inpatient and outpatient psychiatric services informs Lisa's approach to helping folks living with dementia. Lisa is also a certified by the Alzheimer's Association in person-centered dementia care. Dr. Chilakamarri is a geriatrician and currently serves as medical director of the Comprehensive Care Clinic at Frederick Health, including the supportive and geriatric care program. She was formerly the medical director of several long-term and assisted living facilities. Dr. Chilakamarri is leading the movement at Frederick Health to be an age-friendly health system. And we are very happy to have both Lisa and Dr. Chilakamarri at Frederick Health and here with us today. So ladies, I'm going to go ahead and turn my camera off and give you the opportunity to turn yours on. Lisa, are you going to go first, or do you both want to be on the screen together?
I think Dr. C is going to go first, so I can, if I need to turn off my camera while she's speaking, I can do that.
You're fine. There's Dr. C.
Yeah. All right.
All right, ladies, take it away.
All right. Thank you so much. Thank you so much for having us. My name is Geetha Chilakamarri. Like I was just introduced, I'm the medical director of the supportive and geriatric care. Very thrilled to start a program like this in Frederick County. Geriatrics is a practice of medicine, which is, even though it is leaned towards like an age of 65 and above, I think it is a standard of care which should be practiced in any area of medicine. So what we would like to share is start off with what, where, and how, and where we provide the services and so forth. So next slide, please. So where do we provide the services? Our office is located at the Toll House, just opposite of the hospital. And we do have patients who come into the clinic that we see as a traditional medical practice. We also expanding the program to the house where the patients are. If you think about it, how can we expect a sick person or a person who is struggling to kind of handle their overall health to come to a location, to come to us and to seek that service? So to go back to that house call practice, we started that just not as a consulting, but also primary care. I'm going to talk a little bit more about that in the next few slides. We also provide services to all the congregate living facilities, meaning the nursing homes, assisted livings, group homes, wherever the patients are, basically. We are also utilizing the telehealth, like say if some of the family members are living in different states, and as we all know, during this last couple of years with COVID, they're unable to travel to be next to the mother to do this consult with the clinician. We do that group video chat and get that information and get all the team members of the family to be connected. So this telehealth has been an amazing tool to do that family meetings for us. So we provide that service as well. And we provide, our team is also in the hospital. We see patients in the emergency room. We see patients in the ICU, in the med surg, like in medical surgical units, like the regular floors in the hospital. And I believe strongly in, medical care doesn't stop at 5 p.m., right? It has to be continued. It has to be care anywhere, care anytime. If you were to be sick, you should have that access to that person who is providing that care during the day. So you should be able to reach that person whom you saw during the day. So it's a 24/7, 365 days. Next slide, please. And what are the domains of the program? What do we do? when we do come to see the patients or the residents, it's an integrated care approach. It's just not based on a medical care. It's also to understand the whole person and how it affects the well-being, right? It's just not medically, the numbers look great, but functionally the person is not looking, no improvement from before. It doesn't make any sense. Your potassium improved, your chest x-rays improved, but functionally unable to care for self at home or do not have that emotional or psychological help. How are they going to thrive? How are they going to have that meaningful life? So that is the basis of the program, to just not understand the medical conditions, but how it impacts the well-being of the whole person. So we provide the symptom management, right? And sometimes we may not even understand the diagnosis behind it, but we can still provide the healing. We can still provide the comfort. So these are the domains of the program, basically. Next slide, please. And what do we do is we provide, one of the big aspects I strongly believe in is advanced directives, understanding how life will be with all the medical conditions that we carry, and anticipatory guidance. The cool thing in medicine is, we can treat that acute condition in an acute setting. That is the medical practice all along. The new practice of medicine, which is geriatrics and also palliative care, is to anticipate how this person is going to be with all this medical conditions, with this kind of a social support. How can we make this life meaningful the way they think it is meaningful, right? In their person-centered way. And do that in a calm settings of a home. It doesn't make sense to have this kind of discussions in a very, very hectic emergency room setting, but to do it in a very calm setting. It is in their home environment, having their loved ones listening in this conversation to support them to make those hard decisions sometimes. We also support the hospice graduates. We call them, few people do so well once they get on hospice that they graduate. Hospice is it's a service provided by Medicare or some insurance companies, right? For a life-limiting illness. But what if this person get better after the service? Where do they go then, right? But they're still homebound. They need that support. Whom are they going to call once the hospice ends and they're still living and thriving? So we provide that support to them once they come out of hospice. And say, if they were to decline again, we communicate back to the hospice and bring the services back on. We believe very strongly that as much as we provide aggressive medical care, we also need to provide aggressive comfort care, right? Keeping that as a focus and understanding truly what brings meaning to the life. And seamless transition. It's such a fragmented healthcare. We have specialists for every area of the human body. But how do you create that seamless transition and connect the forces in this fragmented healthcare? And advance the support to the most complex patients in the community. How do we do that? And how do we even recognize and know the definition of what makes them complex, right? Even recognition is a big one. So that's another part which we are doing in the Comprehensive Care Center here at Toll House. Next slide, please. What do we do? How do we provide the services is, even though it sounds very, very complex, the cool thing about geriatric practice of medicine and what geriatricians do is we make the complex things simple, multiple simple bite size. So it is easier to swallow, right? So we use a standardized culture curriculum. I'm going to talk a little bit more like what do we do? What are the basis of how we provide the services? We participate with the Advocates of Aging in the Frederick County, which is a huge blessing. And we collaborate with the Frederick County Senior Services Division. And like it was mentioned earlier, we are thriving to become the age-friendly health system, just not the system in a healthcare, but also in the county. Next slide, please. And why the name supportive and geriatric? It is a part palliative care. Palliative care is nothing but, palliative care is not hospice. Palliative care starts from the time of the diagnosis. It is a care which walks from the day of diagnosis alongside. If you imagine, a good analogy would be a coach, somebody who is walking with you and telling you this is the right path to take. These are some other supports which exist. How do you kind of connect that forces and also understand their own personal values, right? And have the person who is having that disease and the family together make that decision based on the values, right? That's what palliative care is about. And there's a major overlap with the palliative care and geriatric care practice of medicine. And we combine both of those here at Frederick Health, and hence the name supportive and geriatric care. And we are using an age-friendly approach of care across the system. Next slide, please. So this is the culture curriculum I was talking about. How do you provide this complex care to this most vulnerable in the community? The basis is you need to ask and you need to connect with the person. You may call them a resident, a patient, or an elder. You need to connect at a human level to understand what matters most to them. You cannot just pose a question as simple as that. Nobody is going to open up to tell you the most important things for them to a stranger, us. It takes a lot of training behind it to kind of connect at that human level, to give them that kind of a reassurance that it's a safe place for them to share that core values. And just not that, once they share that values, how are we going to use those values to give our recommendation as a healthcare, right? To medications, and how do they impact what matters most to them? If they're taking 15 medications, and the most important thing for me is, for example, not have to run to the bathroom multiple times because I'm on a diuretic, like a medication which can make you urinate more, we can adjust the medications. How are we going to know unless you connect at a human level to understand their values and what is most important to them during the day, right? That comes the medication part of it and how it impacts what matters to the person. The next thing is meditation. How is their cognition? Just not assuming and coming to a conclusion that a person who has gray hair has dementia, right? Or a person who is very well dressed and looking amazing and speaking appropriately, but has cognitive deficits. Unless we kind of have that in back of our mind to assess, you would not know. So that's another AM we do is meditation, understanding cognitive status and the mood, like depression, and also understanding some acute confusional state, which happens while they're at the hospital. So we also check the delirium. Unless you think about it, unless you assess it, you would not be seeing it. Another cool other area is the mobility. How are they moving from one location to another? Just not from home to the outside in the community, but even within the home, and how it impacts what matters most to them. So these are the 4M approach for the age-friendly health system, to have like 4 major pillars. I'm not saying that this is the only thing we do, but we use this as a strong basis. And the core thing that we do is what matters. We work very hard on that. We continue our trainings and coachings every week to talk about what else we can do differently to kind of connect with this person to understand what matters most to them. And it's a dynamic process. What matters to you today will change to tomorrow, right? So keeping that in mind as well. Next slide, please. And goals of age-friendly health system, it is, the 4 M's I just mentioned, it is a highly evidence-based practice in geriatrics. Geriatric medicine is not that evidence-based actually, but this 4M is one of the most studied and most safest approach. Unless you do all this 4, you're missing something in the geriatric practice. It reduces harms very clearly, it has been shown, and it is consistent. If you think about it, it's doing the right thing for the patient, unless you understand what matters to that person and the family. Next slide, please. Lisa, you can go to the next slide. Oh, we lost you.
You did? That's funny. I'm sorry. I still see it on my screen. You're not seeing it. Let's try this over here.
think we came to the slide 10.
Is it, there it is.
There you go. You got it.
Sorry about that.
You're fine. Thank you, Lisa. For the inpatient hospital part of the program, we provide both palliative and geriatric care. Like I said, it is supportive and geriatric care. We provide in the emergency room, ED's emergency department, ICU, and also in the med-surg units. We provide only adult palliative care at this point. The consult includes an interdisciplinary approach. We include the social worker, nurse practitioner, geriatrician, resource nurse, who is Lisa. Next slide, please. And the outpatient part of the program, meaning outside of the hospital. And again, this is also palliative and geriatric care. Primarily, we started off as a consultative program where we provide the consults across the community, like in the nursing homes, in the assisted livings, in the congregate living facilities, and in the homes, right? So the next thing we are doing, which we are very excited about, is providing that transitional primary care. PCP is the primary care physician role. Like if a family who had moved here, or their physician retired, or they're in the process of looking for that geriatric care practices, we take over that traditional primary care role for the family and the patient. And say, if you want us to continue as a primary care for the patient and the family, we do. We do provide that home care, primary care from a geriatric perspective. And next slide, please. I'm going to talk about what it entails, like what do we do and how do we provide the service?
Dr. C, can you quickly tell folks what palliative means? Because I know there's a lot of confusion about that.
Mm-hmm. Palliative care, thank you for that question. Palliative care is a very, very new practice, like a, how should I say, it's a new consultative. It's probably 40 years old. People are still learning about the term palliative. Palliative care, as a textbook answer, is coordination of care, right? For a person who is living with multiple chronic medical conditions. It is not about end-of-life care. It is about how you live till the end. Hospice care, if you were to compare hospice with palliative care, hospice, it's for a life-limited illness, and they do have like a age factor to it where they have to estimate that they have 6 months to live, right? That part doesn't exist in palliative care. Palliative care is from any stage of the illness and any age, and it doesn't matter what stage of the illness they are in. It is to provide that coordinated care, and you can still see your primary care physician while you're getting the palliative consult. It is to provide the symptom management, meaning if you're having a variety of symptoms because of this chronic medical conditions that you have, that symptom management occurs through the palliative care. The uniqueness we bring from supportive and geriatric is we use that geriatric care principles that before we make a diagnosis, we look at all the medications to see, is this a side effect of the medication combination or one of the medications which is causing the symptom, right? So that is the uniqueness we bring by adding the geriatric care to the palliative care practice of medicine. Did I answer that question?
That was awesome.
Yeah. Next slide, please. So how do we provide the service? Like I said, again, we are using the basis of a 4M of, what matters most to the patient, understanding their mobility and medications and mentation. The whole consult includes, it's a team approach where there's no hierarchy, right? It is not like a medical practice trumps the social supports. It all affects the person, how they have a meaningful life. So our team includes nurse practitioners, NP stands for nurse practitioners, MD is a physician, myself, and resource nurse, who is Lisa, who is actually my personal coach, who tells me how I speak and how I do things with the team. And we have social worker, whom you all know, most of you may know, is Michelle Ross, doing the advanced care planning truly in advance, right, in the calm setting of homes. And we work closely with the community health workers who can connect with the resources which are available in the community, right? And dietitian who can come to the homes to just not talk about like, these are the number of calories you can have in a day, but also to talk about how you can adjust your diet with the psychosocial conditions that you're living in. So it's a very crucial part of the team. And also a counselor, right? And we have telemonitoring services, which are nothing but, and again, this is some of the tools that we use. Do not forget the most important tool we use is to connect with the other person and understand the true values of the person, right? So the telemonitoring services are nothing but, making sure we know their weight, if they have a congestive heart failure, and it can be adjusted, the medications can be adjusted if we know the weights of a person, right? Knowing their blood pressure, their pulse. So that's what the services are about. And we do have a pharmacist, a geriatric base actually, who can come home and do the medication review during the transitions in the healthcare, like moving from a hospital to the home or nursing home to the home. Next slide, please. What is this home-based care that we are offering? We are not home health. There's a lot of confusion. If we are the home health, we do not provide like a home health aid. It's a medical model, medical psychosocial model, I should say, but we are not home health. But we do work very closely with Frederick Home Health Services, who provide that physical therapy, occupational therapy, and speech. They have their own social worker and a nurse. We do work very closely with them. And if we feel as a team working with the family and the patient that they benefit from this home health services, we consult and continue to work with them as a team. We are not hospice. We are palliative care. We are geriatric care. We are not hospice. We do work very closely with hospice. And if we do see that, recognition of end of life, or if we see that this family and the patient would benefit from that service, we work very closely with them and let the hospice kind of, do that transition. And like I said before, if they were to graduate and do so well on hospice, we will catch them again out of the hospice. And we are not home care aid agency, but our social workers would work very closely and provide that support and, find you that resources with the help of community health workers. Next slide, please. So what conditions do we help with? These are just as an example, but there are many other conditions, which kind of multi-complexity which comes from the aging, and how does that affect the person as a whole, and just not targeting one medical problem, but to understand how all of this interconnect and affect the function of the person, right? And also the medication. How does the medication interact with the disease? How does the medications interact with each other? And how are they all making that person feel, right? This whole interconnectedness is what we provide. And these are some of the conditions which we help with. And the top one, dementia, which I'm trained in through the geriatric practice of medicine and working very closely with Lisa. We do provide the dementia services as a comprehensive care model of having a resource nurse being that coach. Lisa would work with the families to understand the behaviors, understand the anticipation of what life is going to be once you have the diagnosis of dementia, and how do we plan accordingly. And our nurse practitioners doing visits at home to adjust the medications and also be very, very careful how over-the-counter medications can affect a person who has dementia. So, and the social worker to help plan for the advanced care planning, recognizing who should be that person who is making those decisions once you're unable to make those decisions, right? Doing it in very advanced. And that's the program, just like dementia, for every diagnosis you can think of, how it interconnects and how it affects the person functionally. That's what we offer with this program. Next slide, please. And how to reach us? This is our office. When you do call this number, 240-566-3031, you would be reaching Becky or Kyle. And you ask for an appointment. And the other way to reach us is a website. If you go into Frederick Health and click on us, and it shows you, it gives you exactly where we are located and so forth. This is where our office address is. And next slide. I think we just have a picture of our team. Yeah, these are the real people behind this program. Thank you all, and I'll take any questions if you have any. And Lisa, if you want to add anything, please.
Thank you. Thank you, Dr. Chilakamarri. I think it's interesting to note that the emphasis on allaying suffering is related to what matters, because what matters to folks has a great deal to do with what constitutes suffering for them. And it's not always just physical pain, that is suffering. There's lots of ways to suffer. And in order to address somebody's personal suffering, you have to know what makes them suffer. And it's not, so you can't just ask them what's their pain level, because that won't really tell you that. And that's one way to think about this whole approach, that you're really trying to address suffering at a deeper level and help someone live a life that does not have any or as much suffering in it.
Dr. C and Lisa, what a great presentation, and what a blessing for our community to have a program like this right here in Frederick. So again, people who are listening to this thinking, oh my gosh, this could really be helpful, they can call that phone number and make an appointment, and someone would meet with them and evaluate whether they're a good candidate.
Mm-hmm. That's right.
Mm-hmm. Are there people who are not good candidates? Like, would you tell someone you're not ready for us yet, or how does that work?
I don't think, I'm trying to remember if we had any criteria where they would not meet. I don't think we can see pediatric patients. That's about it.
Okay. So we've got a few questions here about insurance and coverage. So how does that work?
Yes, we do take insurances. What we do, everything is billed through Medicare, just like you see, or whatever insurance that person has, right? Like any other consultant that you would see. And it can be self-referred. It doesn't have to come through a physician to consult us. It can be a self-referral. You can call the office and get an appointment. And what I would suggest is, if you were to call and if you have a question that if your insurance covers our visit or not, if you let the person, the front desk person, know that this is your concern, they can do the check and give you a call back and let you know that this is covered service through the insurance.
So we actually have a specific insurance question, and I don't know if you can answer this, but so Kaiser Permanente has patients here in Frederick County, but they themselves don't offer palliative care. Do you work with Kaiser patients?
I can ask our billing person to see how it would work, but I think it is beyond my scope to kind of I don't give you a wrong answer.
Right.
So my manager.
Yeah. So Rosemary, I'm going to suggest that you go ahead and call the office and ask the question again, and then they can get back to you directly. That's a great question.
I would also, if I can add to that, Christine, please. I think that if it's a service that Kaiser does not offer, then they can probably also answer the question about how that would work. Because if they don't offer the service, I think they're responsible and to some degree to help you get it if you need it. That leaves you vulnerable to their decision about whether you need it or not. But you might also just be able to call them and ask them how they handle that.
If someone's insurance doesn't cover it and they wanted to pay privately, is that an option?
Yes.
Okay. Fantastic. All right. Hold on. I'm scrolling through the questions here. And again, for those of you who are listening, you can go ahead and use that chat feature to type any questions that you may have. I also see that McGean has written down your phone number and put that link so folks can get that. And again, the recording and the slides will be available after the event. So let me just read this really quick. Okay. So you mentioned that you do work with facilities. The person writing has a dad who lives in a memory care unit in a local assisted living. And she wonders if this 4M approach is something that she can expect to have happen there with their staff. So she, to this point, has not had, it doesn't sound like a very good relationship or a lot of communication with them. If she were interested in having something more like what you're talking about happen with her dad, how does that work?
Reaching out to wherever the facility is, right? Asking their administrative staff to reach out to us, and we can come over to the building and see the resident there. And we can provide the consultative services in the facility where they are.
Wonderful. And if someone has a physician that they have had forever and they love, but they really like what you're talking about, can people use your service and still keep their physician, or do they automatically take you on?
No, you can keep both.
Okay.
We can keep both, yes.
And if I could add on to that last question about the fellow living in a memory care unit, we have done trainings at a number of facilities in the area around helping folks living with dementia. So another option is to talk to them and ask them if they've had that, and if they haven't, to suggest it, because there's no cost to them. I just go and do trainings with their staff.
Fantastic. As someone has asked, can we access this slideshow to share with family members out of state? And again, if you're okay with that, ladies, we'll share this with the viewers later.
Yes, please.
Fantastic. So Dr. C and Lisa, are you offering training to other physicians about this 4M approach to care for seniors?
Yes, we are, and it is on the website too. The reason I'm laughing is with the COVID, everything is kind of, it got disrupted. But our goal is we are starting even within our healthcare system to reach out to our colleagues and talk about, how valuable this is and how, it's a solid approach to anybody who is coming into the healthcare system, just not an older adult. But how cool it would be if you understand the core values of a person and connect the care plan according to that, rather than just a disease-oriented, but make it a person-oriented.
I cannot argue with that. That really is a beautiful thing.
I've heard Dr. Chilakamarri educate many doctors on the phone.
Much appreciated. Folks, if anyone else has a question, we are very lucky. As I can only imagine, Lisa and Dr. Chilakamarri are incredibly busy people, and we are really lucky to have you with us here today. So can someone access a portion of your service versus the whole service line?
Yes, absolutely. Absolutely. And the way we see it as this is a service, and I feel this is to benefit the person and the family, right? So in any way possible, and we do not see it, we see it as a big privilege that we are able to provide the service. So any part of it is.
Excellent. And again, I really loved that piece that you mentioned before, that you can pull in family from other locations so that everybody's literally has a seat at the virtual table to talk about what might be best for mom or dad or the person they're caring for.
That can be a lot easier with a third party involved also.
I think that absolutely it can be easier with a third party for sure. Anybody else have any other questions for Lisa or Dr. Chilakamarri? How long has this program been available?
How long has it been in the existence?
Yep.
Oh, since COVID.
It's kind of evolved a little bit, right? Through the COVID pandemic.
It evolved, but I would say it is 1 year old. But to be up and running, we keep adding services and we keep expanding and evolving it. So it was established in September of 2020 as the supportive and geriatric care, the name and the establishment of it. But once we had more team members come in, it was more like meant to be team. like everybody, we all share the same values, in believe in connecting with the person rather than, seeing patient after patient, but truly being mindful in what we do and what we practice, even within our own team. So it kind of feels like family for us working together, which I never believed in my past job. So I really feel this is like dream come true for us.
Well, I'll tell you that I've heard Michelle speak, and she communicates the same thing. You can really tell that you guys have a very cohesive team. We're lucky to have you. Someone has asked, can you share a success story or share maybe some examples of some of the work that you've done?
Yeah, absolutely. So from my own personal experience, I can tell you, when you hear a complex patient, right? It was, oh my God, it's so complex. It is so intense for the patient and the family and the healthcare system. And we get consulted through the healthcare. I'll start with the story of a consult from a healthcare level, right? One of our colleagues consulting us, creating that whole scenario of, oh my gosh, all this complex medical conditions, right? And the family who are unable to understand, or what we call, it's a very difficult family dynamics, right? And we hear that. I'm keeping it very transparent from a healthcare level. It becomes very difficult to kind of engage all the family members and to see that, oh, how come one person gets it and another person doesn't get it, even within the healthcare system. So what we have done is first asking the patient, and just not assuming that the person doesn't have the capacity to understand, but truly keeping the focus on the person and saying what matters to them the most and what makes their life joyful and meaningful, right? The first time we talked about this, everybody kind of, even myself a few years ago before I had this level of training, it kind of sounds like, how are you going to answer this question? What gives meaning to your life? How does a good day look to you, right? What brings true joy for you? And what if I told you that, look, you have 6 months to live. Where would you like to live this 6 months or 1 year, right? And just not focusing on the medical conditions, but to say, tell me about your dad, right? Tell me everything about this person who is sitting in front of us now. And once the daughter started to speak about this person and the other family members are listening, right? Listening is the huge tool we use, right? More than our stethoscopes. And then truly understanding how the patient is responding to the daughter speaking, how much she knows that this person values, and the rest of the family members listening in, and how they all connected. And, once this happened, the rest of the medical care discussion, understanding the prognosis, just not talk about the medical conditions, but how all of this would impact their function and their lifespan, right? Doing this heavy lift of connecting them together, the rest of it was easy. It's a piece of cake to talk about the medical part of it. So that was kind of cool that once you come out of it, you feel so joyful. We did not do any open heart surgery. We did not fix anything. We could not prolong the life, but they all left feeling happy and content that they are.
And connected with each other and with the patient. That's a beautiful story that I'm sure some of our folks viewing can resonate with.
We had another situation in which a patient was declining and had some acute things happen, suddenly. So there was a big change suddenly, and everybody was very sad and distressed over the what appeared to be the trajectory of this person's life. And the person kept trying to communicate to the caregivers, and this actually was not mostly family, this was other caregivers, that there was one thing that they wanted more than anything else, which was to have a copy of several newspapers that were important to this person. And that kept being ignored because it certainly wasn't as important as medication, or wasn't as important as other things. And we got to know the patient and got to know the patient's family, and learned that this person was really somebody who thrived on being an intellectual and learning new things, and learned what that person was interested in, and instructed all the caregivers what they like to talk about and how important the newspapers were. And they started getting the newspapers, and that person has turned around and is improving and doing really well. And that you just don't, who to thunk it, right? Like, right. This is what Dr. C went to medical school for.
And yeah, you can't write, you can't put that on a prescription pad. And that is, there's so much more to our senior population than the typical medical approach can see. So it's really beautiful to see your very holistic approach.
I think I lost you guys for a second.
Just giving you lots of praises, Dr. C.
You still there, Dr. C?
Oh, there she is. Now, the connection went off for a second. I'm sorry, if I missed any.
You're good. Okay. You're good. So we do have a good number of professionals on the call. So I guess 2 points I want to make. One is that if they thought they knew what you were all about 6 months or a year ago, it has very much changed, and they should reach out to you. Mm-hmm. And as far as referrals go, can professionals make referrals to you directly? And I'm hearing you say that families can call you directly, correct?
Absolutely. And it's a service. So what we believe in is it's a service, and we feel fortunate to provide the service.
Fantastic. All right, folks, we're at 1:45. We're not going to take up anybody's time, but I don't want to let any questions go unanswered. If you have a question, this is your chance to get them in. While folks are typing, perhaps, Lisa, do you want to just give the contact information one more time?
Sure. Let me pull it up here. Our office number is 240-566-3031. And you can also look us up on the Frederick Health website. If you Google Frederick Health, and then there's a services tab, and we're supportive in geriatric care.
Fantastic.
McGean put it in the chat as well.
Excellent. So hopefully everybody can see that. And again, just take my video off. I will be sending out, we have a list of all of our past presentations, all of our webinars, a link to the videos. We will put this video together and get it up on our YouTube channel as well, so that you'll be able to view this or share it with other family members. I will also follow up with an email that includes the contact information for the Supportive and Geriatric Care Program. I'll send that out later today. Next month, as I mentioned, we are hosting folks from hospice. Here it is again. Thanks, McGee. So next month, we will have Patricia Ortiz-Miguel speaking about hospice. So we learn more about palliative care, and Dr. C and Lisa certainly mentioned the hospice program. You'll hear from them next month. So hopefully learn something new there. We are very excited about that. We are going to have a new portal for registering. So I will send the link out for that very soon. We're going to be registering through a new format. It should look very similar, and we hope it's going to be very easy for you, but we'll get all of that information. Our next webinar will be March 9th from 1 to 2 o'clock, again on Zoom. And again, last chance if anybody has any questions. We're getting lots of thank yous, Lisa and Dr. Chilakamarri. Again, we really appreciate your time and this incredible service that you are providing to the people in our community. It's really fantastic.
Thank you for having us.
Absolutely. All right. With that, everybody, I bid you a great afternoon. Enjoy the sunshine and the warmer temperatures, and we will see you all next month. Thank you.
Thank you.
And we're clear.
Awesome. That was great. Wow.
Great program.
Oh my goodness. Yeah, that's fantastic.
So not counting us, the highest we were 26 participants, not counting the 4 of us. That does include Dr. C and Lisa. So
okay, that's got to be our highest, though, don't you think? Or pretty close.
It's pretty close. You know, you just have to wonder if 40 people registered. You know, what happened to the others? And I recognized a few names on there. So there was a good mix of families and professionals. So.
Yeah, I was interested in the number of you could tell that there were definitely some like airs, like all of the air staff were on. So it was good to see people wanting to learn, which really isn't something I had thought about us providing, but what a great opportunity now that we're during the daytime for people to get that information. So.
Yeah, I think this time definitely works. Much better results.
Yeah, a little kind of crazy to squeeze it into my day, but it is really good. No, I'm definitely excellent.
No, that was great. And I apologize, I forgot to put March 9th on that slide for March.
Oh no, it's all my mother has texted, we've done a good job again. So God love her.
That's great.
Oh, funny.
You know, just a comment. I see Debbie Thaxton was on this one. I know you've asked her to be a panelist for,
The April.
Yeah. You know, I'm just thinking of whatever facility he's in. She just needs to keep it unnamed if she wants to complain.
Yeah, I wasn't quite expecting that.
Oh, was that question from her?
Yes.
Okay.
Yeah.
Okay.
But definitely. Yeah, no, I mean, and we're asking her to speak more about the right, when she was long distance caring for her father before she brought him in. So, and a little bit about the transition, but
and there is an important element about that transition and finding your trustworthy partner in the facility, and finding your comfort zone. And
yeah, because this is the second facility since she moved him in May.
So it's a process.
Oh.
Yeah. But well, and as a principal, and I don't know, I think she probably has pretty high or tough standards. I don't know to put it, but
or as someone who leads people, right? She probably has expectations of how she expects another organization to run.
Exactly.
Yikes.
Sure.
So we've got the 3 speakers for that. I have not, but I will reach out to them in the next week or so and just see if we can't get them starting to think about what that program will look like. And it maybe, I don't know how much we talked about it. I have to look at my notes, but if we want to kind of commune together and talk about what kinds of questions and what path we want that, or what we want that to look like before we meet with them. Just to hash that out a little more.
When do we meet next? Is it
next Tuesday?
Next Tuesday. Okay.
So yeah, we could talk it through then, right, Mary? 12:30. You're still on mute.
You're on mute.
It's like
really not meant to do electronic things. I just really don't like it.
Well, I went through and so Troy has all of our YouTube webinars all of our Compass webinars on a YouTube channel. It's great. Also all the ESPC networking ones. And when you first go to the link, they're all like jumbled, and all it does is give you a date. It doesn't say navigating the holidays, right? So I went through all of ours and I made a list and I put the link in the title so that it made sense who the speaker was, what the date was, and what the title was, so that we can send that out.
That's great.
It'll just be easier. But as I was doing that, the whole record thing, like I'm embarrassed. Some of them are like a good 5 minutes.
Oh,
in.
we're still recording, by the way.
Oh, God.
I totally didn't think about it.